always inspiring us to stay up to date on important topics in ultrasound. Dr. Tasso Drenis, who's one of our PEM faculty, who, like Valesky, is trained in 16 different fellowships, including PEM and ultrasound, and now admin. He was kind enough to not only show me how to do some of these scans in real time, but he lent me some of his stills and video captures from previous studies. And thank you to all for delivering my baby today if she decides to come early. Okay, so I'm gonna talk about the vomiting baby. There were probably a handful of things that I remember from medical school, hearing that ultrasound was the gold standard of diagnosis. And kind of when I went back and was refreshing my memory to what I actually know how to do out of those things, I would say I know how to do maybe 1 of 5. Not saying that our ultrasound teaching is not spectacular, no, spectacular. But some of the things that I remember, like, we don't need to do thyroid studies in the ED. And anyway, let's move on. So I'm gonna start with a case. Let me make sure I know how to use the computer. Case 1, we have a 4-week-old with projectile vomiting. Was born a little bit early, 3 days of projectile vomiting, it's milk. Baby's really, really hungry between episodes of vomiting, exclusively formula fed, nobody's sick. This baby is the only child, so the firstborn male. On exam, the baby actually appears normal. Totally fat, plump, happy baby. The fontanelle is not sunken. Baby's not yellow. The belly's benign. I vigorously search for anything that feels like an olive, but I don't find one. This baby is circumcised. The anus is patent. You step out for a second because you're like, I need to gather my thoughts and talk to my attending. And you come back and mom has just given baby some Similac and you actually see it vomit. And it is projectile. It's never projectile. Can you guys give me some things that you think this is? What? Okay, what else could it be with projectile vomiting? You could get some projectile vomiting with gastroenteritis, a hernia with small bowel obstruction, which scares me to death because I've never seen one, and apparently it's a real thing that people get sued for a lot, and malrotation with midgut volvulus. In the last thing I mentioned, the vomiting would likely be green bilious. Okay, so in terms of a workup for Lisa's presumed diagnosis of pyloric stenosis, what would you guys want to do without seeing all this that's already up there? What? Okay. Okay, so this baby's been sick for a few days. We've actually watched it vomit. It's not tolerating PO. So at this point, I think, you know, some people would say it's very fair to go ahead and put a line in this kid because they're going to need some probably IV hydration. And at that point, we could get some labs to make sure they're not like super, super laboratorically dehydrated, not a word. And a lot of people would consider getting an X-ray. Gross. X-rays in the vomiting kid have some utility, but not much. They can show us something really scary like a perforation maybe, but otherwise they're super, super not specific. If the baby is having bilious emesis and we are worried about malro volvulus, you might want to rule out a perforation before you go sticking things inside of a baby's butt, like an enema. Sorry if that was crude. So what we might see if Lisa is right is some gastric distension, not specific. we can see that there's no double bubble sign. We can kind of see that this isn't something a little bit more scary in this situation. So here's a little bit about Lisa's correct answer. Hypertrophic pyloric stenosis. It's usually a pretty young baby. It is a surgical emergency. It doesn't have to be corrected like in the exact moment, especially if the baby looks super well, but this can't be left to go on. Baby will lose weight, baby will get sick, baby will fail to thrive. It's usually the firstborn male. It's usually a light-skinned firstborn male. For some reason, bottle feeding makes it more likely. Intrauterine exposure to cigarette smoking and macrolide antibiotics. I can't explain that, but it is a thing. Sometimes when they're preterm or C-section, and there is some kind of familial component, but it is polygenic. So again, I can't fully explain that. The incidence is about 5 in 1,000 live births, which it's not trivial. And what we end up seeing anatomically is hypertrophy, not only circumferentially, but also longitudinally. So when we start looking for this, we're going to start looking for something that's not only fat, but also tall. Long. So kind of like the very obvious presentation I gave at the beginning, a baby will present with postprandial, usually non-bilious feeds, non-bilious emesis after feeds, and will be very hungry between feeds. Once you get to a few days of having lots of vomiting, baby can show signs of dehydration. You can see these on labs. You can sometimes see these on the physical exam. It would not be out of reason to get labs, particularly a chemistry, just to make sure that this baby is not super, super dehydrated. But you can get the laboratory abnormalities of dehydration. So hypokalemic, hypochloremic, metabolic, alkalosis. The palpable olive is not usually there, by the way. I've never seen one. Has anyone here ever felt a I'm sure our attendings have, but any residents ever felt an olive? Me neither. So ultrasound is absolutely the gold standard for hypertrophic pyloric stenosis. One of the things that I found when I was doing the research for this presentation was that emergency physicians are actually really good at this. We're really good at this with minimal training. I had never done this, and maybe it's because we don't spend as much time in peds as we do with adults, but this is something that we can be doing as soon as we have like any suspicion for this, and it can decrease the length of stay of a baby in the emergency room by 1.5 hours on average, which is nuts. So yeah, there is a huge role for this in the pediatric ED. As of right now, there is a lot of training happening for PEM faculty and PEM fellows. When I looked at a few studies comparing how sensitive an ultrasound is between PEM or EM attendings versus a radiology or GI, PEDS GI or PEDS radiology attendings, the sensitivity was not so different. So for EM attendings, 96.6%, we'll pick this up. For the radiology attendings, it's 100% usually. In terms of the specificity, as you can see here, it's just EM attendings, 94%, radiology attendings, 100%. In the study that I used to get this hard to look at chart, the PEM faculty in the study basically had to undergo a 4-hour course once a year that included like hands-on diagnoses of hypertrophic pyloric stenosis. So when you think about it, it's not really that much. And we talk about when we talk about ultrasound, especially some of our faculty that hates ultrasound, we will mention the pitfalls of intra-user reliability when we're using ultrasound. And a lot of this data is showing that with such minimal training, we can do a really, really good job of this because we are awesome and smart and good at our jobs. There are, depending on which paper you're looking at, like slightly different statistics with regards to how well the EM faculty compares to radiology faculty, but it's really not, the differences are super slight. Some more evidence saying how good we are at our jobs. It's kind of just what I just said. Just wanted to prove it to you. Okay, so how do we actually do this? Getting baby into the proper position will be very important. So a fasting baby is preferred, and here is why. I didn't know this until 2 weeks ago when I was attempting to learn how to do this myself, but milk doesn't look great on an ultrasound. And I was trying to understand why, because I'm like, it's a fluid. It should look like fluid on an ultrasound, like water, but it doesn't. There's a lot of stuff in it. It makes a bunch of beelines, makes it very hard to measure anything. The fat content, the air content, it's different than water. Who knew? That baby that just had the Similac or a baby that's just breastfed, if you're gonna go and you're gonna try to do this exam, it's gonna be really hard to measure if they've just had milk. One of the ways that you can kind of counter for this is to position the baby in a decubitus position where they are leaning so that the milk flows back into the antrum of their stomach. So that would be, let me just think about this for a second, to the left. And if you are able to have an empty stomach, one thing that can be very useful is to give this baby something clear like sugar water. And if it's just sugar water in there, then you can lie them to the right so that the contents of their stomach is flowing through the pylorus, which gives us a great acoustic window. Okay. You can also just lie flat. In terms of choosing your probe, you want to choose the highest frequency. Oftentimes you have to compromise for penetration, which is why we use different probes for different things when we're in the ED. But babies are super small and a linear probe should get us everything we need. In terms of starting this exam to find the pylorus, one thing that I learned when I was trying to do this myself, but there's a couple places you can get stuck. I confused what I was looking for once. I thought I was looking at the pylorus and I was looking at the GE junction. I know they seem like they're pretty far apart, but you know, we make mistakes. The easiest way to do this is to start by finding the gallbladder. I think we're all relatively okay at finding a gallbladder. One of those gold standards that we actually know how to do pretty well. So you find the gallbladder in the transverse midline. And once you do that, you can usually locate something that looks kind of like this. Where's my thing? It's not there. Something that looks like this. And you'll see the antrum of the stomach on one side and the gallbladder on the other side. And you can be fairly certain that that's your pylorus. That is a kind of very basic computer drawn diagram of what we're looking at. So the gallbladder should be right next to the pylorus and the antrum of the stomach right there. This would be a very thickened, both circumferentially and lengthwise pylorus. And this is what we're going to try to see on the ultrasound. Well, that video didn't. We'll come back. I have a video here of how to find the pylorus that Dr. Drennis provided for me, and it was great. And you can just believe me when I say that. Okay. Well, we'll just go to the measurements. So pylorus has 4 key measurements. The first one being the most diagnostic. We want to measure the thickness. So when we're thickness circumferentially. So when we're in a short axis, we want to get this kind of view. It looks kind of like a target, which is my next case will also look like a target. We want to get a single diameter of the circumferential muscle. Circumferential muscle is what this darker appearing area is that I'm measuring. If it's over 3 millimeters, that is diagnostic for being too thick. So pyloric stenosis. You can also measure the length. You get into a longitudinal view. Over 15 millimeters long is diagnostic. Last time when I tried to do this, I could not get a good view of the transverse short diameter, but Dr. Drennis did it with absolute ease in a video that I'm not going to show you. But over 13 millimeters in this cut is diagnostic again. And then there's one more measurement, which is the volume. When you put it into our sonocytes, you can measure it using the bladder volume measurement tool. But in terms of the volume of the actual muscle, over 1.5 milliliters or centimeters cubed is diagnostic. The one that we're looking at here is within normal limits, it's 0.12. Some signs that we can look for just by grossly scanning through the pylorus. An antral nipple sign shows some of the muscle protruding back out into the antrum that shouldn't be there. That's a redundant fold and indicates that there's too much muscle. The cervix sign, it looks like a cervix. That is what it does. And then the target sign, we kind of talked about that before when I was talking about getting that measurement. Okay. Case number 2. There's a 24-week-old male with non-projectile vomiting. So he's 6 months old. He's had 2 days of postprandial vomiting. He doesn't look so great. His appetite's decreased. His energy's low. He's fussy. Mom thinks he looks pale. He's not making enough wet diapers. The vomit's starting to look bilious. And he's making some weird movements. He's lifting his legs up to his chest. She's never seen a kid do this. And he's really tired between the episodes of feeding, which is not great. Mom has 2 kids. Both kids had a viral URI last week. On exam, baby's tachycardic, looks dry, looks dehydrated, fairly consolable by mom, doesn't look yellow. When you look at the belly, there's this retraction of the right iliac fossa. So when you're feeling the right side of the baby's belly, it feels kind of empty in the right lower quadrant, but more full in the right upper quadrant. You don't feel anything that feels like a hernia though. And when you look at the testicles, they look normal. You always have to look at the testicles. What are you guys thinking in terms of a differential? Great. What? Could also be, again, we always have to think of malrotation with midgut volvulus in these babies that are vomiting. If they're a little bit older, not even a little bit older, but over 2, between 2 and 7, we could think about appendicitis. Again, a hernia, colic, they shouldn't look quite so dry. Okay. Workup is kind of similar to the last time. I might throw in a CBC in this case because some of these kids can bleed. Again, with the x-rays, they're terrible. One thing I will say about abdominal x-rays though, is when we're comparing them in terms of how trivial they are in terms of exposure, the millisievert dosage of a plain film abdominal x-ray is not much. It's something around 0.25 millisieverts. When we are talking about a CT of the abdomen, we are talking about 15 millisieverts. So this is relatively trivial, but still it's going to add up. If you're doing these both before and after reduction or doing them for the fluoroscopic guided enema, it adds up. But it isn't the worst thing in the world for you to simultaneously get an x-ray. If whoever said intussusception is right, we have an interesting rule at county. And I'm sure this is in existence in many other institutions, but I just learned about it here. Every child that is suspected of having intussusception has to have a plain film x-ray first. There is a very good negative predictive value of an x-ray that shows bowel gas all the way through. So what we kind of are looking for with the plain film is a paucity of bowel gas distally. And if we see that, while it's not specific, we can't rule out intussusception and the workup needs to go further. Sensitivity of the x-ray for the condition, if it is intussusception, is 48%. And I included some statistics to remind us how good we are at reading scans again. as read by EM faculty versus radiology faculty, we do pretty well. So as I mentioned earlier, the X-ray can be a useful adjunct. It can at least tell us that the baby is not hugely perforated, which can happen with these cases. If it is intussusception that we're talking about, the longer that the baby stays intussuscepted, the more risk we have for gut necrosis and spillage of gut contents into the abdomen, which is horrible and will kill you. Okay, so you were right. Intussusception, it is a disease of babies. Call it a surgical emergency, even though now most of these are corrected by air enema or barium enema. The air enema can be, you just kind of shoot some air up there and you can kind of see if the situation has resolved with the ultrasound. With the barium enema, it needs to be done by radiology and they can use an X-ray to see if everything is corrected. Epidemiology, it's babies. Again, males more than females, sorry guys. In many of the babies that get this, there's no like tumor that explains why something is telescoping. But the reason I mentioned that this kid maybe had a viral upper respiratory infection in the past week is that the leading prevailing theory is that hypertrophy of lymph tissue in the ileum provides a lead point from which these telescopes can retract. The clinical presentation, the triad of pain, a palpable sausage mass, and currant jelly stool occurs in less than 15% of patients. I don't know if I've ever seen currant jelly stool. I don't know if I've ever felt a sausage-shaped mass, but it's something that you have to think about when you have a vomiting baby, especially if they're starting to tire out. Again, with this, just like the last thing we talked about, you can get the lab abnormalities and physical exam findings of like extreme dehydration and sometimes anemia if you have a lot of bleeding from the GI tract. The most common type of intussusception is for babies, it's ileocolic or ileocecal, kind of for the purposes that we talked about with the hypertrophy of the lymph tissue. Other things that you can see it with, the rotavirus vaccine, Meckel's, diverticulum, polyps, tumors, vascular malformations, Henoch-Schönlein purpura. Ultrasound is the gold standard. Even if X-ray is interpreted by the best of the best, it's not the most specific. And as I mentioned with everything else, there's a growing body of evidence that emergency physicians are really, really good at diagnosing this. Right now, based on kind of what I said happens at Kings County with the need for an X-ray, if the X-ray doesn't rule out intussusception and there's no pediatric radiologist at the hospital, what usually happens to these babies is that they go to observation overnight, which is okay if this is like the first or second day of their intussusception. If this is the 5th day of their intussusception, they could die. Just saying. Rarely in the United States does a baby die of intussusception anymore, but it is still fairly common in developing countries. And like I mentioned, peritonitis to sepsis to death. And sometimes there's like intestinal infarction that disrupts the blood supply, and it's terrible, horrible, no good, and very bad. We're good at our jobs. Okay, so how do we actually do this? So you're gonna put the baby in a supine position. Depending on the age of the baby, it might be easiest to have them lie in mom or dad's lap. We're going to use a linear probe again. Babies are small, frequency is great. And we are going to make a square on the baby's abdomen because we want to trace the entire colon. Best place to start is where that kind of retraction was in the right lower quadrant. The psoas muscle, the abdominal muscles, and your iliac vessels will give you your bearings. This is something that needs practice. I had a hard time doing this when I tried to do it the first time, but I think that with practice, you will get very, very good at it. I know you will. It's really important to scan all 4 quadrants. These are things that I borrowed. One is from SAEM and one is from Brown. They were actually really helpful when I was trying to learn how to do this. Again, liver, gallbladder are very, very helpful anatomic landmarks for finding where you are. So whenever I get lost with any of these, I just find the gallbladder, the liver, and go from there. One of the scans came through from POCUS at least. Okay, so what we're looking for is a target. We want to see this kind of bullseye. This is a short axis view of an intussusception. And next to it from the POCUS atlas is both a short axis and a long axis. And this was done by one of our previous PEM fellows at Downstate, which I thought was awesome. And this is like the clearest I've ever seen the kind of long view. I don't know how to pause this, but if you can kind of appreciate when we go from the target to kind of the long view, you can totally see can you guys see it, how it's like telescoped? Cool. So that's what you're looking for. While there is a measurement that matters, if you measure the diameter, it's usually more than 3 centimeters. Just seeing this, you don't actually have to have a measurement to see that this is intussuscepted. And that's what I'm going to talk about today. Do you guys have questions? Cool. Dr. Kilpatrick?